Welcome to the third Dundee PRN vodcast. It's December and the weather outside is frightful, but our vodcast is still delightful. And today we're talking about eye movements, the muscles of the eye and the nerves that supply them.
Let's start by looking at the plastic model of the eye to get ourselves orientated. Here's the eyeball, swivel round to the lateral aspect and concentrate on lateral rectus muscle supplied by the abducent or sixth cranial nerve. We'll represent that with the colour
green.
Now I want you to think of superior oblique muscle over here on the medial aspect of the orbit, passing through the trochlea and inserting on the posterior aspect of the eyeball. Superior oblique is supplied by the trochlea or fourth cranial nerve, represented in pink. The rest of the muscles are medial rectus, superior rectus, inferior rectus and inferior oblique, all being supplied by the oculomotor or third cranial nerve, represented in blue.
Okay, hi, I'm Ross, and today I'm representing the nose, medial to the right eye.
I'm the lateral rectus muscle supplied by the sixth cranial nerve abducens, and I abduct the eye away from the midline to look laterally.
This is the medial rectus muscle supplied by the third oculomotor nerve, and I move the eye in medially.
And I am the superior rectus, used to make the eye look up, and the inferior rectus, used to make the eye look down, also both supplied by the oculomotor nerve.
Note how all of the muscles are inserting into the eyeball in front of its pivot of movement. Let's consider the two oblique muscles, and first of all be absolutely certain that they're attaching to the eyeball behind its pivot of movement, whereas our four rectus muscles were attaching in front of that pivot. We're not going to think about the anatomy, we're going to think about the movements of these muscles in relation to testing them on patients.
I'm the superior oblique muscle, which is supplied by cranial nerve 4, the trochlea, and it's so called because this muscle loops over the trochlea up here, and when this muscle moves the eye down and in.
I'm the inferior oblique. I'm supplied by the oculomotor nerves, the third nerve, represented in blue, and when I move the eye upwards and inwards.
If we now look at this clinically and ask the patient to look to the right, we see that the lateral rectus and medial rectus move the eyes to the right and there's no double vision.
If, however, there is a palsy of the right sixth cranial nerve, lateral rectus and the right eye will not be innervated, and if the patient tries to look to the right, this will happen and the patient will have double vision.
We're now going to talk about palsy of the fourth cranial nerve, the trochlea nerve, which controls the superior oblique muscle. Superior oblique muscle is used for looking down and in, which is typically for going downstairs, for reading, and so on. In the event of a unilateral palsy, then when the patient attempts to look down and in, the unaffected eye can do so, but the affected eye cannot. In a patient who has bilateral fourth nerve palsy, they often adopt a characteristic head pose of looking down with their head, so their eyes don't have to do the downward look.
In an oculomotor nerve palsy, all the muscles supplied by this nerve don't work. So that's the superior rectus, inferior rectus,
Medial rectus.
Inferior oblique.
So in an oculomotor nerve palsy, the only remaining functioning muscles are lateral rectus, supplied by the abducens nerve, and superior oblique, supplied by the trochlea nerve. So in a patient like this, the affected eye would drift down and out with the combined actions of these muscles.
It's also worth mentioning that because the oculomotor nerve also supplies the muscles of the eyelid, the patient would also have a ptosis.
Okay, so I've found the discussion about eye movements, muscles and nerves fascinating and educationally very important. But I would really like to know a bit more about pupils.
Well, in talking about pupils, we want to talk a bit more about how the eye is related to systemic disease, disease in other parts of the body, and not just functions of the eye muscles and of the nerves supplying the eye directly. So we have been joined by our lovely anatomical skeleton here, but there are of course pupil problems that originate entirely within the eye, aren't there?
So we just discussed an oculomotor nerve palsy. In an oculomotor nerve palsy you would actually see dilatation of the pupil, which is different to something called a Pancoast tumour.
Okay, so a Pancoast tumour can make the eye have a constricted pupil, known as Horner's syndrome. This is because the Pancoast tumour is found here in the apex of the lung and it interrupts the sympathetic chain.
Does that mean that you have constriction of both eyes?
No, it's just of the pupil on that side.
Okay.
So if you have a left-sided Pancoast tumour, you'll have a left-sided Horner's syndrome, which is a constricted pupil.
Right.
And of course, the point with Horner's syndrome is you have retention of all the eye movement, so that while you have ptosis and a constricted pupil, which means you won't be able to see very much, you can actually move the affected eye in all the directions because it's not affecting those cranial nerves.
And of course the reason the pupil is constricted is because the sympathetic innervation is knocked out.
So the parasympathetic innervation takes over.
Yeah, exactly.
And of course there are lots of other systemic diseases that reflect in the eye that have much wider range than a simple tumour. For example, Wilson's disease has a very characteristic set of rings around the iris, and that's really nothing to do with the eye, it just happens to be a deposition within the eye itself.
And that's of copper, is that
Yes.
right? Yeah. Just checking.
That's great. Should we finish there, or are there any other questions?
Just to recap that diseases in the eye aren't just within the eye, as Marge said. We've also learned in previous systems about hypothyroidism and things, so just have a look at that.
Diabetic retinopathy,
Many things, yeah.
The list is endless, isn't it, frankly?
So don't just think it's located in the eye, think beyond the system, the symptoms you're seeing in the eye.
Well, thank you very much to Ross, Imogen, Fraser, our skeleton, Katrina, Marge, and the veritable Professor of Clinical Anatomy, Professor Ian Parkin. Goodbye.
We've mentioned ptosis, but not said a great deal about it, and we ought to remember that levator palpebrae superioris is supplied by both the sympathetic system, sympathetic trunk, and the oculomotor nerve. So an oculomotor nerve palsy gives ptosis. Horner's syndrome, interruption of the sympathetic system, also gives ptosis.